system, and then finally quality improvement strategies. So that's our approach to performance management. And I think on the next slide, okay. So you were familiar with this one. We have 5 key components in our efforts to decrease cavities in California. Water fluoridation, kindergarten assessment, community clinical linkage, that's the school-based, school-linked program, Head Start, WIC, and primary care providers, all the linkage programs. And then we're increasing dental visits, and finally oral health literacy. So all these efforts are geared towards reducing tooth decay. The way we measure it is through kindergarten oral health assessment and a statewide survey of 3rd grade children. So that's how we measure prevalence of tooth decay, untreated tooth decay, and sealant prevalence. So in measuring performance, what we want to know is how much are we doing with respect to all these different activities, how well are we doing, and finally, is this making children healthier? So this is our approach to performance management. Next slide. Okay, so one key component is kindergarten oral health assessment. So we want to make sure we this requirement is met, and also it's not only meeting the requirement, we want the data to be reported to a central warehouse, data warehouse, where we can where data will be available at the local level. So in my opinion, in our field, oral health, the biggest gap is local level data, and especially local level current data. And we can get some data about, county level data about services and how many children receive services and all those things, but we don't have health outcomes data. That's why I'm really excited about, promoting this kindergarten oral health assessment, gathering the data, measuring performance at the local level with respect to some outcomes. And Trevor, you can take it away.
Excellent, sounds good. Yes, and so one of the frameworks we use to manage our indicators and our performance measures is results-based accountability. And so basically in a nutshell, our performance accountability, or RBA, is comprised of 2 kinds of accountability. One is population accountability, whole populations and geographic locations, and performance measures. So those client populations and how we measure that. And when we're looking at performance measures, we, as Dr. Kumar alluded to, we ask how much did we do in quantity, how well did we do it, typically with a ratio or percent, and then is anyone better off? And that's really what we're going after, especially in California. We also ask questions, the 5 core questions in turn the curve thinking. So when we look at our scorecard a little bit later, we'll see a graph, and based on the curvature of that graph in relation to our target, we'll want to ask those 5 core questions behind the curve. And we'll talk a little bit more about that later in this presentation. So the benefits why we use RBA at CDPH is because this is start with ends, works backwards step by step to means. It's data driven, it's transparent. We can share this data with other partners that use RBA, and it would be the same, understanding the same data, it would be transparent where everyone can make the same conclusions. We use plain language to avoid jargon, to avoid confusion, to mitigate error, and we try to keep it simple. And I think it's also important to elaborate on RBA that we're really trying to move talk to action. So when we're all said and done, we really do want to implement that action plan and move forward instead of just talking about it and hoping for the best. From here, RBA definitions. So when we break out population accountability and performance accountability, we have 2 types of definitions per accountability. And population result being cavity-free children in California. That's establishing the condition. We want healthy cavity-free children in California. So that's that population and geographic location. And our indicator for that is the kindergarten and 3rd graders caries experience rates. And when we look to implement a strategy, we call upon the KOHA, Kindergarten Oral Health Assessment, in the state. That's the program and agency that we are working with to move forward in achieving our goal. And as we assess what's happening with our program and our strategy, we look at the performance measures. And so we look at percent of school districts participating in KOHA and the percent of children with oral health assessment. And a little more about performance measures, as I alluded to earlier, how we look to ask, how much did we do? We ask the number of school districts participating in KOHA and how well do we do it, the percent of staff trained to promote KOHA, and is anyone better off, the key, percent of kindergartners who are caries free in the school district. And that would be great. And then when we do look at the scorecards, and again, we are gonna ask, how are we doing? What's the story behind the curve? Who are the partners that have a role to play in turning the curve? What works to turn the curve? And what ultimately is our action plan for turning that curve? Let's see if I can move forward here. And there's a little bit of a freeze, a little bit of a technical issue here. Let me see, maybe it'll, okay, that's all right. So, and how are we doing? So this is the first graph that we use from our scorecard for percent of school districts participating in KOHA. And as we can see in the red, this is our target at 55%. And we see over time from 2011 to 2019, the improvements and depressions in that curve. And this is where we're gonna actually explore each individual scorecard, understanding what's going on here. Why are we going up or spiking some places and dropping? And the same for percent of children with oral health assessment. Target of 35%, and looking to see what's going on here. After we talk about what's going on behind these curves, we do want to look at what are our actions. So it's really important as part of RBA to identify 4 of the key criteria for creating an action plan. And leverage is actually really important. This is the notion that your actions address those root priorities, those root causes, the story behind the curve. So when you're looking at historical values or even forecasting, we're asking ourselves, if we don't do anything right now and this curve is going to stay on this trajectory, is that what we want, or do we want to improve that? So we looked to leverage to see how we can address that priority health inequity or disparity in that story. We also look to see if it's feasible. Do we have resources? Do we have personnel? Can we make this happen? Values are important. Is this consistent with our core values, our shared values? And finally, specificity is very important, because this is the who, what, when, where. We really want to know down to the specifics. That way there's no confusion and we can mitigate error as we implement our plan. And so I'm actually going to go out of the presentation real quick and pull up the scorecards. We can look at school districts participating in KOHA first. And this is really what I like about RBA framework and using the Clear Impact tool, is that it creates a learning environment. It creates a data community where if we're all sharing in this framework and we're all using this tool, then we can all use this together and have simultaneous viewing and continuous collaboration. And so as I alluded to earlier, we look at the story behind the curve. And when we're looking at the story behind the curve, we're looking at restricting and contributing factors. What's restricting us from achieving the goal, and what's inhibiting us. And so we found with the percent of school districts participating in KOHA that data collection and entry into the SCORE database is restricting us, as Dr. Kumar alluded to earlier. Training and tech assistance on SCORE and local health capacity and infrastructure. When we look to see what those contributing factors are, we do see the existence of state laws and policies, the availability of funds, which we really like, parent, student, teacher, dental professional participation. We have a community involved to help us reach this goal. We also look to see, and we anticipate, so availability of funds, as we always anticipate that, and availability of trained staff, which is key in implementing something like KOHA. And so we are partnering with the California Department of Education, California Dental Association, Children Now, our LOHPs, school districts, and our Dental Hygienists Association of America. We know that having a champion to inform, educate, and work to outreach other decision makers is important to us. It's critical with respect to this particular plan. And strengthening the policy by passing resolutions supporting the oral health assessment implementation is also key. Developing a partnership consisting of dental professionals, LOHDs, and school districts to implement the screening is going to serve a big impact. And as always, making available funds to support the administration and assessment requirement, facilitating data gathering, processing, reporting, and assessing progress and taking steps to improve performance along the way. So as new data becomes available, we want to ask, is this good? Is this bad? What do we need to do to change or to improve that? And I'm actually—
Trevor, you want to stop here and take questions, or?
Sure. Yeah, let's do that.
So why not you go back to the curve? Let's look at the curve, what's happening.
Yes. So we do see over time, 2016, big jump here between that 1 year.
Yeah, and then dropped, and went up again and dropped back to where we were in 2011. This was totally unexpected. And we think why it happened. This is when the contract changed from CDA, contract with San Joaquin, this core database, changed from CDA to CDPH. So now in CDA supported that contract from 2011 through 2018. And this is when we switched. And there was probably some communication gap. And we think that's one of the reasons why this number dropped. And there was some confusion. School districts were sending the data to CDA. So this is what we think happened during this time. And this is also reflects, so this one indicator is percent of school districts. The next one is percent of children. So we know from Medicaid, for example, 50% of 3 to 5 year old receive preventive dental visit. So if it is 50% in the Medicaid population, it's a lot higher in privately insured population. So this number, so we came up with this goal of 35 for what the target is 2025. Mm-hmm. Trevor, something like that.
Yes, that's correct.
And so this is an easily achievable target because the assessments, in my opinion, it's being done, but it's not being reported. So if we get 50% reporting, this is 35%. If we get something around this or a little bit higher, then what happens at the school district level, the data, you can say, if I did a survey of kindergarten children, I get about 35, 40% if I use active consent. So, it becomes fairly, large population-based data. So the percent cavity-free and percent untreated, those are the two other indicators that is reported. Mm-hmm. So those two, you can rely on those two figures and see if we can make improvement with respect to that. So training and technical assistance on SCORE, our contract includes that they provide training and technical assistance to school districts about gathering the data and reporting it. So there are, a couple of, COVID. So this is going to make it worse. Next year, it's going to drop precipitously. And then hopefully we'll have all this, local oral health program capacity, infrastructure, SCORE database, technical assistance, all these things will be available in 2021, 22. Then we want to turn this curve up. So what are the action steps needed to achieve that? So that's what Trevor will discuss. So in our opinion, if you go back here, what works? LA school district never reported the data, right? So LA Trust decided to take this upon and introduced a resolution, passed it. So now that, all LA schools are supposed to report it. So we think that this is the key thing. Having champions in the community to promote this is key. And then, of course, partnership, dental professionals, local health school districts. So this was done in San Francisco. That's why, they get all 4,000 children assessed every year and gathered the data. So, and now funding is available to local oral health programs. So there's one big gap. I think Dr. Shakalpi Pendurkar is on the line. She can tell us how well it has worked. The biggest challenge I see is school districts have to tally this. There are two ways they can report the data to SCORE. They can report individual level data, or they can report aggregate level data. So aggregate level data requires them to tally, percent of children with cavities, percent with untreated cavities, all those things. That's a lot of work for them. So, and they're submitting individual level data, that's also a lot of work. So we funded a pilot project in San Mateo. Okay, so Shakalpi is ready to talk about that. What's your experience, Dr. Pendurkar? We think that's one of the reasons why the reporting is low.
Hi, Dr. Kumar. Hi, everyone. Thank you. This is my first KOHA work group meeting. I believe Lizette used to attend while she was our epidemiologist. And when I came on board in San Mateo a couple of years ago, we had probably just one school district that we had an agreement with at the time in terms of helping with KOHA reporting. And so when I came on board, what I did was I reached out first to the Office of Education, San Mateo Office of Education, and talked to the superintendent there and asked if, they were okay with us approaching the schools and approaching the school districts and the superintendents, individual school districts, because as we know, every school district has its own autonomy. And so once we had their blessing, so to speak, we made some presentations. The different school district superintendents have an association, at least in San Mateo County they do. I'm not sure about elsewhere, but I would imagine it's probably the same. And so they have periodic regular meetings. And so we went and presented at a couple of their meetings and just kind of got the word out how important it is for the school districts also to kind of push on, participating and requiring. We found out, what I realized was that a lot of school districts were not even aware of the requirement of the KOHA requirement because it's not mandated. And so we provided information, we talked about what it meant to participate, and it was obvious that a lot of school districts were struggling because A, they did not know, B, the ones that knew did not have the resources or the manpower to sort of go and upload, the KOHA data that they might have collected even. So what we ended up doing was we have agreements now with, I believe, 7 or 8 school districts that we can collect their actual KOHA assessments from the CUMES. We also made a big push at Bayshore School District a year and a half ago and just sort of said, we'll come in, we'll help with the screenings if your students don't have a place to go, and we'll collect the KOHA information at the same time. We'll also do fluoride varnishes at the same time, and we did that pilot. And then collecting the KOHA copies from the CUMES, from the school districts, and then helping get that data uploaded to SCORE. Lizette was, doing that at some point. She also partnered, I know Brendan, I think Brendan is on the call, and she worked with Brendan to sort of pilot that scanning prototype or protocol that you guys were trying to figure out. I'm not sure what happened with the actual scanning prototype, but my understanding is that there's some, there might be some movement on that. And that was, again, to help to ease the uploading of the data, because I feel like that probably is one of the challenges that school districts face in terms of, okay, we have the data, but to actually go into the score site and to put that into the score site is a challenge. Now, of course, this year, for the last obviously 7 months, it's COVID has just thrown us a curveball, and we are all struggling with how to move forward with that. I've had multiple conversations with the Office of Ed. There's a school nurse there now who's assigned with, working with the Oral Health Coalition and our program. Just asking, about when school might want us to come on board again, possibly to help with screenings, or possibly to help collecting the forms. But there hasn't been any real movement on that. And I believe, I can understand the challenges the schools are facing, but I feel like there might be some way of leveraging the Office of Oral Health and maybe the Office of Ed at the state level, and seeing if there might be some way of bringing about some movement in that direction. But that's sort of where we are. And like you said, Dr. Kumar, I think, yes, we are going to see definitely a drop in numbers. And I just feel horrible about that. We had all the ducks lined up in January or February, at least in San Mateo, to move forward with the school-based programs and to scale it up. And now we're sort of waiting on the sidelines to hear back from the schools.
So Brendan is on the line. Brendan, can you talk about scanning project?
Yeah. Can you hear me?
Yeah.
So we got the results from Lizette, and it definitely looked promising. So what we did at the state level is had our IT basically like pilot test a system, or I guess build a system similar to what you did in San Joaquin, with just to see what if it would be feasible to go about doing this from at a larger scale. So we built it.
Brendan, I don't think everybody knows about what Lizette did.
So, okay. Just based on what Shakopathy talked about, so I'll just say what we built was a system where you could scan the KOHA forms and then just send the PDF to somebody. So theoretically, in San Mateo, they gave the forms to Lizette, to the San Mateo Department of Public Health, and they scanned the forms there. But any scanner can be used, and you just need to make the forms into a PDF, the filled out forms into a PDF, and then you run those PDFs through a software, and it populates a Excel form ready to be uploaded into SCORE. So basically, it's a way of taking data input and making it, just making the data input process, data entry process a lot easier. So we set up a system like that in with our IT at the California Department of Public Health, because what Lizette had done is she had done this based on the old scanning, the old KOHA forms. They're technically still the current KOHA forms, because the ones that this work group worked on starting 2 years ago, I think, to revise, have not yet been approved by the Department of Education. But at the state, I had our IT build the scanning form, or build the scanning project, sorry about that, based on the new KOHA forms that not yet approved, but we have the KOHA form. And so really a lot of what we're doing with moving forward, trying to move this forward, and a lot of things that we're trying to move forward with SCORE is being delayed by these new forms not being approved.
I'd like to ask a question, if I may.
Yeah, thanks. Go ahead.
This is Marcella from Riverside County. And Brendan, I'm trying to wrap my head around what you guys did. Unfortunately, I'm really visual, so it's hard for me. But the form that you are scanning and then creating it into a PDF to then be forwarded and transferred into an Excel spreadsheet, that's kind of what I hear you saying. My question is, that form, before it's scanned, is that something that is just filled out there on site with the individual child?
So the KOHA form, as it is the basic KOHA form,
Yeah.
As we use it, is a form that schools typically send home with children. Their parents have it filled out at the dentist's office and then return it to the school.
Okay.
This can be done as much as, I think, 6 months before the start of kindergarten for the children. And so that's typically how it's done. So there are plenty of examples of school-based screening programs. So these screenings could be and are in many cases done at school. So there are different ways that you could do it. You could literally just fill out one of these forms for each child as they are screened. It doesn't take a long time.
Right. Well, I mean, I'm a mom of a kindergartner who's first grade now, but I did this last school year, and it was very, very simple.
Yeah.
And at the time, I had just joined the oral health program here in Riverside, and was barely, getting a taste of what oral health is. And I thought to myself, this is so simple. I really don't understand why other parents and school districts are challenged with completing it. It was part of the packet I got when my son entered kindergarten. So I just sat down and filled it all out, and it was done. So I really didn't understand, the challenges with getting it done. But I'm wondering, I guess it would be really interesting for me to be able to see all of the steps that you described, to be able to see that maybe in follow-up meeting, because it sounds like it was really well done and it had a positive outcome.
Dr. Kumar, may I speak?
Yeah.
So Marcella, what you said is absolutely true. Unfortunately, what we've seen is, even in San Mateo, was a lot of school districts were not even aware of this requirement, although it's been in effect since, I believe, 2008, if I'm not mistaken. So that's why one of the things which we did do is we pushed for it, like with the enrollment packet, just like you got one with your son's enrollment packet. Just making sure that school districts understand that just as you're asking for immunization records, please ask for this form to be filled out. And even if the form comes back from a parent saying, I opt out or I don't have a dentist, we still wanted that information. So the first step we did was we just kept on hammering, at these superintendents meetings, when we went out to the schools, when we talked to the school principals or the teachers, is just saying, please add this form to your school, to your TK or kinder enrollments. And then to Brennan's point, the school-based programs where we would go and we would screen, we are using and we're making sure that the community, we have partners in the Oral Health Coalition, and they all understand that we are still using the actual KOHA form, not the updated one, which is still in process of updating, but the one that is out there and has been out there from 2008. So just a push for using that. So when anyone is doing a school-based screening, we are pushing for the use of the KOHA form so that that form then can be used, for getting information into SCORE. So those are some of the things which I think every county could try to pursue that route would be helpful.
Maybe we should look at the action plan. Trevor, you want to move to the action plan? What? Okay.
Dr. Kumar, did you want me to talk a little bit about the action plan?
Yes.
Okay. Yeah. So as part of RBA, the action plan is key because this is where we're getting back into the specifics of the plan, by whom, by when, what they're doing. And so we can see here that requiring all LOHJs to promote KOHA as part of their grant work plan objective is key, and we are still on track with that by 2022. If I may also just interject, I think Dr. Pendekar had a great point about how the school districts weren't aware of the KOHA, and making it mandated would be a key. And so I'm not sure I see that right here on this list, but pursuing potential legislation or making partners at the legislative level, I think could also be of significant importance that would make it required or mandate rather throughout those counties. But nonetheless, item 2, providing technical assistance, training resources, and toolkits. Yes, this is with our partners at UCSF and KOTAC, which is currently ongoing. Same with the funding, UCSF Tech Assistance Center, Office of Oral Health, and that had already happened, it looks like, Dr. Kumar, in 2018. Same with supporting San Joaquin County of Office of Education to establish the central registry, I believe to what Brendan was alluding to earlier. But what's still ongoing is going to be the second to last item, requiring all LOHJs to promote KOHA as part of their work plan objective, which again is still the same as the first. It's really important, but nonetheless, I think we need to probably insert something new there to be more moving that talk to action, pursuing the mandate route would be one recommendation in this action plan. And providing tech assistance, training resource toolkits, looks like that's also there, still ongoing. Dr. Kumar, that's really all I have right now in terms of action plan. I'm also getting, similar to Marcella, I'm still kind of getting a taste for oral health as well. So I've been with the office since about May, so I'm playing a lot of catch up, and last 5 months has been a bit of a fire hose with understanding all these plans. So nonetheless, I'm going to get all this. And so yes, Dr. Kumar, is there any additional action items that perhaps we could amend or add to this list that we feel?
So this is what we did, 2017, 2018, the ongoing support, working with San Joaquin County Office of Education. So are there other things that we should consider?
I think, Dr. Kumar, if you want, I can share the MOU that we've been using in San Mateo County to partner with the school districts. I can share it with you or with KOTAC. I can send it to PACO, and perhaps that template can be used by other LOHPs if they wanted to do something similar. I found that if you have an agreement, if you have an MOU like that with the school district, it helps them. It sort of in some way takes a little bit of the burden away from them so that they don't feel like they're pressed for resources, and we are here to help. So yes, it is a little bit time consuming for the local health jurisdictions to go out and maybe make copies or go through the CUMES and get those KOHA forms, but it is still a step in the right direction, I feel. And then if the scanning works, as Brendan says, in the future, then that might actually be even easier just to scan on site. But I'm happy to share the MOU that we've used.
Thanks. I think Mary Jane has a comment.
Yeah, I do. Thank you. So Dr. Kumar and Dr. Pendekar, I feel I'm with you. We were so close to this universal screening pilot model with more LA Smiles under the Dental Transformation Grant, and then boom, COVID. So it's really unfortunate that we are probably not going to be able to see that project to fruition, but we still are looking at the kindergarten mandated data in LA. And so we've collected data with UCLA, and I can tell you last year, what the data that we had with more LA Smiles and the other oral health screenings that we had were about 77,000 kindergartners. But when you look at the data internally that the state has through SCORE, it's 177. So I'm really excited about this scanning technology, which Brendan was talking about. And Brendan, you and I probably need to connect offline, because the other news is, as things happen, LAUSD's data staff transition. So I don't know who's in charge of kindergarten mandate, but I had such a beautiful person to work with, and now they've moved on. So Trevor, while you try to get a drink out of the fire hydrant, we're looking for somebody else who can drink out of a fire hydrant, which is LAUSD. But the other thing is that the, talking to school nurses around, parents just check waiver. So it's like, is there anything in the results-based performance that we want to look at or consider around, again, not just returning the form, but actually have a reported screening? Because I'm not sure what the total N would be if we just looked at waiver forms, but that's concerning. So I think there's opportunity for parent education, and then for community partners like us to do exactly what you're saying, and that's promote kindergarten oral health screening and probably step that game up a bit. Thank you.
Thanks, Mary Jane. Yes, Brendan, can talk to you about the scanning project. So here are the intervention activities to meet objectives we listed. So we can add all those things here. We can add more activities here. So we established, we included, this is an objective in our LHA grants. We made, we have a work group. We contracted with San Joaquin, and we enhanced that system. So those are all done. Training, UCSF. So all these things have been done. So what other things can we add to the list of activities? So we can look at WAVED as another indicator, Trevor. So there are 8 indicators, and we can think about that. We can add other indicators as well. So any other activities to turn the curve?
I have one.
Of course, this is going to be a parent education about importance of kindergarten oral health screening. Okay.
Dr. Kumar, have you met with the School Boards Association, CSBA?
Have we met with them? Okay. So the contract with this San Joaquin County Office of Education, Rosanna, can you help me on this one? So they are supposed, they go and meet with school boards. They regularly they meet with several groups. County Board
Jay,
of
do you want me to
Education.
jump in?
Yeah.
Okay. So we haven't, as the Office of Oral Health, haven't met with the School Boards Association in a long time, and that was pre-Dr. Kumar coming here. But we have been working with Department of Education, and they are intending, once the forms get finalized, they are in the final stage of approval at CDE, that they will send a cover letter to all the superintendents of school that will be signed by the state superintendent and Dr. Kumar to encourage them to participate in the kindergarten oral health surveys, and remind them it is part of the education code, which means that's how the law is implemented by schools. to encourage them. But another thing that on the local level that can be done is to work with the local control funding formula, that every school district has a parent advisory committee, and they are supposed to look at the funding plan by the school district and approve it. So if there is a lot of buzz by parents to say we need to perform the kindergarten oral health assessment and we want it to be part of the local control funding plan, then it's more likely to get done. Because then even though there's still money coming to schools, it gets all blended, and it's up to the schools to determine what is best for them to implement. So if this can be raised as a higher priority, we might get more schools participating. And as some of you know, there are schools that don't even know that this is either required, or that their schools have been doing it all along because they never knew that it was no longer up to them to, or not required per se, as how it used to be when it was first passed. So there are quite a few activities that can be done at a local level to get awareness up, both with parents, school districts, and actual schools.
Can I have follow up on that? I apologize for the cat yowling. Yeah, two things that I wanted to comment on, and one was a previous comment saying, wouldn't this just be better if it were mandated? And so I just want to, highlight the complexity there. It's not exactly not mandated. It's not funded specifically. It's, as Rosanna said, it's part of their block of money that they get, and they can choose to spend it on this or not, right? So it's more complex than just saying we need to mandate it, because that's probably not a feasible solution. And then my second comment was, I think that you should put a list together of these other umbrella groups as allies. Somebody in the chat said the school nurses. I said the school boards, and I was gonna say the PTA association. There is a California state PTA associations, and start with a high level education. If you can get in front of them to talk with their board leadership of those bigger organizations about the importance of this, you may get more traction in disseminating information. And I would, bring to them a presentation and a one-pager and ask them to disseminate, because building those allies and those partnerships with the high level, the nurses, PTA, school boards, county office of education, maybe teachers associations, the teachers unions, you may find more allies in the districts and get some ground traction with demanding that this be done in the individual districts. It only takes one person to hear that and say, one school board member to say, why isn't my school board doing this? They can bring it up and make it happen. So that would, instead of going individually to every single school district and making the case, if you can make the case to an umbrella organization, that I think would be a good use of resources. Thank you.
And I think those are great suggestions, Daria. And one more thing to add is that when talking with schools, to frame it as far as a way to prevent chronic absenteeism, since dental problems are one of the #1 reasons kids miss school, and to talk about the financial incentive for them to incorporating KOHA. That is really a meaningful message to them, because they are really looking at how to address chronic absences. And it also comes into why it could be a priority for their local control funding plan, because they get additional money when they outreach to underserved students. And this is a way to keep them in school. So that's another rationale for it.
Rosanna, don't we have in our contract with San Joaquin County Office of Education something about attending the regular meetings and including KOHA as part of their presentation?
No.
No, it's mainly to do a training on how to use SCORE, and also a guidebook so that if they're not at a computer, they can look in the binder that has their password and all that it takes, copies of forms on how to walk through accessing SCORE, because that's one of the reasons schools said it was so difficult, because if they couldn't get through on the 800 number, then they didn't know how to actually manipulate the database and upload it. So this was to address that concern. And another concern was that when staff left, the school district could not get access to SCORE because they didn't have the password from the person before, and they weren't allowed to get a new password without the old password. So they've, and Brendan can expand a little bit more how they're going to make it more user-friendly, and also have identify who has access. So, and then identify the number for San Joaquin to contact if they need to change.
And thank you for bringing that up, Rosanna, because that has been a big issue. I mean, even when Lizette was trying to work this scanning thing, you know, her feedback was trying to get access to SCORE is a huge problem. So for some reason or the other, like just what you mentioned, you know, getting that password, they usually have like one person that they've identified from and linked to a particular site or a particular school, and then that's it. So if that person leaves, then the next person cannot access it. So hopefully that has changed.
Yeah, and another change that they made is originally the 800 number went to one person at San Joaquin, and now it's going to be going to their 800 I don't know what you call it, like team that answers the 800 calls. So they're hoping to respond to calls within 24 hours of receiving it, if not sooner. And this way they have a whole team of folks to respond to those calls versus one person. So hopefully that will help with the backlog.
Okay. So this could happen, you know, this meeting with school boards, PTAs, nurses. I'm sure it also happens at the county level. So it's both at the state and at the county level, I think. And anything else we should be thinking of? Any other ideas?
Yeah, this is Mary Jane again, and I'll just say that we had quite a bit of success sharing data with the school board, data that these were not actually being done a few years ago, and now showing with the investment of the school board and the promotion, the championship of the school board, that we were able to make some strides. And we just have to bring them back. But again, like we're just in this space where they're just trying to make sure kids are getting their academic needs met and are connected and so on. So this issue is not top of the slate, but
Right.
we are constantly reminding them. So whenever I have an update with school board members, I'm just like, we've got to bring dental back. Kindergartners need to be screened. And they're like, yes, yes, yes. We have not lost that, but you know, again, it's priorities right now.
Okay.
Should we put together like scorecards for each county on participation rate or something?
Say it again, Brendan.
Should we put together like scorecards for each county saying how well or poorly they're doing in participation and SCORE?
Actually, you know, we are pilot testing with 3 counties, right? Shannon?
Yeah, we're pilot testing with 4, actually. Alameda also joined the group. So we hope to meet with them after proceeding.
So every county should have a scorecard like this.
Yes. So right now we're piloting to make sure how, because there's been some concern about making sure that utilizing this is very efficient. So we're trying to come up with a template and as well as a manual to help local health programs and scale it up. So we're piloting to find out what is the most efficient method for implementing RBA.
But having county scorecards would be very useful in lots of different advocacy.
Yeah,
I mean,
yeah.
taking the time to do that.
Scorecard per se. That's an RBA term. But yeah, just like a little fact sheet that just does like a little infographic for each county.
Yeah, I mean that's would be a very useful tactic for advocacy too. A county fact sheet, we can then use that in lots of different ways to advocate for.
Yeah, and that was actually something that we had done a few years ago, where we had developed for a certain number of counties, like a one-page snapshot of participation, and then trying to make that argument, connecting it to absenteeism and ADA dollars and what have you. So I'm happy to dig those up and share them with y'all if you'd like to use that as sort of a jumping off point.
That'd be great, Katie. Thank you.
Yeah, of course.
So, what we did was we developed a lot of tools for local oral health programs to do this advocacy. So the next project directors meeting, we are going to focus on media advocacy. So our plan is, use the Children's Dental Health Month in February to talk about this requirement. So we want all local oral health programs to make this as their top priority for their Children's Dental Health Month. So they can talk about, the rates of who is participating, not participating, why one school district is doing better than others. So there are a lot of ways they can approach the media and pitch this requirement and how well their county is performing as opposed to another county. So we're going to focus on that one at the upcoming Project Directs meeting. So it's about media advocacy. Earning free media coverage for this as part of Children's Dental Health Month. Okay, Trevor, anything else?
That's all
on the scorecard?
The scorecard, yeah. We do have kind of what we were talking to earlier, talking about establishing the more specifics about that, about what we would implement next or what would be our next steps that we'd want to implement. But other than that, yeah, I don't have any other additional items here.
Yeah. So go to the next table. Okay. So we will, based on your input, we will fill this one and leave this assigned to, leave it blank, and come up with some due date, right? And then we start tracking the progress, whether we have made the presentation to all these organizations, whether we have trained local oral health programs on media advocacy, and how many, what happened during the Children's Dental Health Month. I mean, this 2021 February is not it's going to be tricky. So any other idea if you have, send it to us. We can, expand on this action steps here.
Mm-hmm. Yeah, this is Mary Jane. I'm sorry, I'm going to have to sign off. I have to take another call at 3. But I know, Dr. Kumar, that you are working with Maritza on the launch of their local campaign for kindergarten. So like whatever can be doubled down in that opportunity with advertising would be great.
Okay.
Thank you.
Mhm.
Thank you. Okay, thanks.
All right. Thanks, Mary Jane.
Dr. Kumar, may I ask a question? So I was looking at the chat information that Rosanna put in there, which I'm aware of, that the $8 is not tied to the KOHA forms anymore. Do you have any background information as to what made that change happen? Because it was mandated previously. As Trevor pointed out, the mandate would be really helpful. And then the mandate was taken away. So now the school districts really don't have to do this. They still get the money. And that's why multiple times we hear that this is a requirement without any teeth. So what was the reasoning behind it? And is that possibly a way to go about and trying to revert that back to, you know, sort of attaching those $8 to actually getting a form filled and making school districts?
You know, I can talk about in general. Okay, categorical funding versus block grant funding.
Mm-hmm.
Okay, but Rosanna knows the inside story. So you talk about any funding. What locals like is flexibility. Okay, what the state and federal government, what they like about giving that flexibility is they can give them a chunk and cut it by 10-25%. Okay, so whenever they talk about giving flexibility, you should understand that it comes with some reduced funding. So that is in general. Daria, you agree with me? So, right.
I can provide
So
some
that is
more
the
background.
Okay, so Rosanna can give you more specifics about it.
So right around when the Great Recession
No,
hit in
Rosanna, we are having
California.
difficulty hearing you. You're breaking up.
Can you hear me now?
No,
Can you hear me now?
no. So something, you know, similar must have happened in California. So there was a, you know,
Can you hear me now?
crisis. Yeah, a little bit better, I think.
Okay, I'll keep trying. In
No.
2009.
No.
Okay.
That's pretty horrible.
Maybe you can type it in.
I could, okay.
She did put a note in the chat box about it.
So basically, you know, in 2009, there was a crisis budget. So I'm sure that's what happened here in California. So they decided to cut the funding and pool all the money that was going to the locals and said, you have the flexibility to use the money the way you want it. So
yes, it would certainly be beneficial to the statistics of this if we could reverse that.
no.
Yeah, and given
That's a heavy lift.
Yeah, given what you just said, Dr. Kumar, I mean, the funding part of it and the flexibility. So we're looking at possibly all these budget restraints coming up in the next couple of years. So I don't see that changing at all in terms of mandating anything, you know,
Right.
attached to funding. I think the best bet would be, just like Daria said before and Rosanna said before, is to going after the parents and having the parents push for this, I think would probably be the best way, because, you know, that's where the power lies. I mean, and the school absenteeism. I mean, if the children are not showing up, then that has a real impact, obviously. So
at least, you know, now we have close to 90% of coverage. You know, 90% of children has some kind of insurance coverage that they can use. And even the remaining 10%, there is a way to provide insurance coverage. So that is not a barrier to receiving this assessment. Anything else?
if thinking long-term technology as a form gets developed, maybe in the next round, and thinking of as a parent with a lot of forms to fill out, and you know, like if I could just email it to my kid's dentist and have them email it to CDPH or the school district, just something, ways to just cut down. I don't want to have to take another form to a different doctor and then remember to turn it back into the school. So as other conversations are happening about, you know, breaking down silos and using technology like ladders, as we continue to have conversations about EHR sharing, thinking long-term and keeping in the back of your head, I would love to be able to just sign a form that says, my dentist can fill this out and send it to the school district, so that I have one less form I have to remember to fill out and turn in.
Daria, you are reading my mind. I kept thinking about how to simplify this because you get so many forms, and I just kept thinking, can somebody just send me a QR code so I could just do it on my phone and kick it to someone else?
Yes, we actually looked into an app.
Yeah.
So, you know, an app, dentists can have that app, download the app. Parents can download the app, and so there are many ways. We'll continue to explore that one.
Yeah, I mean, I know with my own son, I have 3 apps on my phone right now. I'm looking at it that are related to his school. And so every day I'm on, he's got, there's 3 apps here. I've got one that's a class dojo, which every day, anytime, communication between me and his teacher. Then I have another one that's his classroom, where all the stuff, all the work's being kicked out. And then I have another one with an Aries portal. And in my Aries portal, I have all of my son's school specific stuff. You know, his student ID is in there, emergency contacts are in there. It would be lovely if the medical stuff could be in that Aries portal. I go there beginning of every semester, just double check that everything's good. Emergency contacts are up to date. If my kid has an allergy, it goes in there. And I've got my phone just like you guys. I'm sure you got at least 2 phones with you. The phone is everywhere I go. So if I had it on my phone in some kind of app, when I go to take my son to his dental appointment, guess what? My phone's there, so is the form.
The only issue is for those kids who don't have a dentist, and finding a dental home is a big issue. And you're talking about the underserved kids and, you know, the areas where there are no dentists to see these kids. And that's an issue. And that's why when we get back those forms where parents are opting out because they don't have a dentist, we still want to know that, is because we can then identify. So that's and again, I mean, you know, it would be great if a dentist could say, sure, I'll sign the form for this kid, but without having actually screened that kid, they cannot just sign the form. And that's the other.
And that's not what we're saying. What I'm saying, advocating, is as part of a larger surveillance, and we want to focus on the kids that need, we want to be able to focus there. And if you could use technology to get more parents who have private coverage and have taken their kid to the dentist to just click a button and send it, you would get more surveillance. Take those people off of your to-do list and spend your resources focusing on the kids that need connection to a dental home, right? So there's 2 different problems. One is collecting the data, because you know that in a lot of these, in many districts, you've got middle income families with private insurance whose kids are going to the dentist, and you're just not getting a record of it. So you want to have a record of that, and then you want to be able to focus your resources where they need to be spent, which is getting the kids with no dentist.
No, I agree with you, Daria. We're on the same page. We're both CDA, so no argument there. But
Daria,
you have a point.
Yeah, Daria, well, so speaking on apps and stuff, the trickiest part is you know, HIPAA issues, right?
Of course,
so making sure that all that stuff is HIPAA compliant secure stuff. But you know, any like connection or anything that you want to make where we could just pilot test something like that with the school? Like we already have talked to SCORE about that. They're definitely willing to work with us on something like that. They worked with us on, you know, it was problematic, but with the San Mateo project, and they're a lot better at responding now. Than they were in the San Mateo project. But
and I'm totally, there are so many things to be careful about. HIPAA, technology, parents who are wary about giving the school district access to their kids' health care. It would be a complex nut to crack. However, I think we're particularly in a COVID situation where we're more digitally parents are more digitally connected to their kids' school district than ever before. And we're on the precipice of this being possible. Maybe it's not possible this year, but like in 2 years, we're going to be laughing that we had this conversation because I'm going to be able to connect my Kaiser with my school district in the touch of a button, right? You know, like that we have the technology, we're almost there. I want us to be, thinking about ways in the near future where we could just make this all easier.
I mean,
Could I just add one comment? Oh, go ahead, Shahok. This is Lynn Walton Haynes. You go ahead.
As a clinician, I think for me, if I were able to have a parent use their phone as a camera, look in their child's mouth, and I do the screening and fill the KOHA form online, I would love to do that. So it's really awful that the governor vetoed the teledentistry bill. I mean, now it's going to be another barrier there because now, we have to establish a patient first in a brick and mortar place. And then, so there's all kinds of barriers that are real to making this happen. Just like Brendan said, I mean, not just HIPAA and FERPA, but all the rest of it too, like getting the child and the dentist or a hygienist who can screen and fill that form for those that don't have that, dental home. What do we do there? And so these are real issues. And especially now with COVID, we can't go to those schools. The kids can come to us. So what do we do? So another aspect of it.
Lynn, you wanted to make some comments. I was on mute.
Oh, yeah. Okay, back off of mute. Thanks, Jay. Hey, everybody. Lynn Walton Haynes, Department of Public Health, Oral Health Program. I just wanted to follow up what Daria said. I understand those comments about, get the folks you can, but actually, Dr. Pendekar just sort of underscored what I wanted to underscore again, which was, I know the hardest thing to do is to reach the kids that are hardest to reach that don't have the dental homes, but those are the same ones that when we look at the data in a couple of years, like when we look at the data now, when we see it looks good until we look at the populations that we haven't been able to reach. And so I think, it does require kind of like everything that everybody was saying, as well as, even reaching out to our partners on the medical integration side, like when community health workers are going out to talk about asthma, or they're doing telehealth to talk about asthma with their clients, parents, and kids, and that they're reminding them, you want to get those forms in, or who they can contact, at F2HCs, working with some of our other partner dental associations that are out there doing screenings or doing sort of community events to do these kinds of things. I know sans COVID, but I think we do have to, as both Daria and everyone else said, we do have to focus on those who aren't the easiest to get, aren't the ones with private insurance, because like Dr. Kumar always says, we don't want to widen the gap. We really want to move the needle. We're not going to if we don't get those populations. So I just wanted to underscore that. That's all.
Thanks, Lynn. Okay, Trevor, I think we have a lot of ideas. And, we are not talking about 100%. We're talking about, increasing from 13 to 35% in a couple of years and 50 or so by in another 5 years. So we're not, we're taking little steps at a time. So, okay, there is the curve. So our target right now is 35%. So increasing it from 13 to 35%. And with school district, we can can you go back to the next, previous one graph?
Oh, yes.
This is children. We have one for schools.
Yeah, here we go.
Yeah, school district. So increasing the number of schools participating. If we increase that one, the number of children participating will go up.
Mm-hmm.
So, okay. Anything else, Trevor, you wanted to cover today?
I believe that was it, Dr. Kumar. Action plan, discussion, recommendations, and a good old-fashioned thank you. But yeah, I think we did it. I think we covered good with recommendations here, and we can definitely implement those or add them to our action plan grid. And then I liked what you said earlier. If anyone has additional items or something you think of along the way, feel free to send it to us. That way we can also incorporate that into the action plan and follow up with everyone. That's all I have.
All right. Thank you very much then.
Yeah, thank you. Thanks everyone for coming. Thank you for organizing this.
Thank you, Dr.
Yeah, thank you.
Thanks, everyone. Bye. Thank you for inviting me to this meeting.
Thank you, everybody.
Bye.